Hello, I am Pappa. I'm a cardiologist at Konstantopoulio General Hospital, and I will be doing this presentation on behalf of Mr. Patsourakos. I would like to thank the organizing committee for the opportunity to participate in this meeting, and I will proceed with my case presentation. It is about a male patient who is 55 years old. He was referred to our hospital due to exertional angina over the last months. He had a medical history of dyslipidemia, hypertension, and a positive family history of premature cardiovascular disease. We performed an echocardiogram that had no abnormal findings, and the ejection fraction was 60%. So then we proceeded with a dobutamine stress echo that showed apical wall motion abnormalities at maximal stress. So the next step was a coronary angiography. And this is it. We can see that the right coronary artery and the left circumflex artery are normal, but there is a long, severe lesion in the mid portion of the LAD, and there is tortuosity at the site of the vessel. So we concluded that this is in accordance with the patient's symptoms and the stress echo, so we decided to treat this lesion. So what type of stent should we choose in this particular scenario? We have a long lesion, as I mentioned, which would require a big amount of metal in order to be treated. There is a vessel with tortuosity with over 3 consecutive curvatures of over 90 degrees of angle. So those two elements make it a high-risk patient for in-stent restenosis and late events. So we need to have a stent that will maintain the motion of the vessel and its pulsatility. That's why we chose the Dynamics bioadapter scaffold. It's a new stent platform that has some unique features compared to other conventional stents. It is made of 3 metallic helical strands that are linked together with unlocking elements. At 6 months, these elements unlock after the resorption of the biodegradable polymer coating, and the strands separate from one another and move more freely in comparison with the vessel. So this results in restoration of the vessel motion and function, increase in blood flow, less late lumen loss, and restoration of adaptive remodeling. Here are some other of the features of the new scaffold that makes it superior, probably, to conventional DES. It has a good deliverability and implantability. It has high acute gain. After the uncaging of the elements at 6 months, it enables vessel motion and functional response. With early uncaging, it restores pulsability and compliance and increases blood flow volume. And it also provides dynamic support to the diseased vessel and return of the vessel to the sustained normal function in the long term. It reduces arterial stresses and supports positive remodeling, enabling lesion stabilization. Also, some studies have shown that after the uncaging of the elements, there is the stented segments follow the vessel rotation and reduce event rates at the long-term follow-up. So I'm coming back to the coronary angiography and the PCI of the left anterior descending. We prepared the lesion with a compliant balloon and proceeded with stent deployment of a Dynamics of a diameter of 2.5 millimeters to 28 millimeters of length. And after the deployment of the lesion, there was additional residual stenosis in the proximal segment, which we decided to treat as well with an additional Corflex DES, 3 millimeters to 19 millimeters of diameter. And the final result was the one that you can see on the right of the screen, and it was very satisfactory, and we ended the procedure there. After 1 year, we decided to follow up with a new coronary angiography, although the patient was asymptomatic, in order to further evaluate the results of these scaffolds. We can see that there is a satisfactory angiographic result, although there is some suspicion of in-stent restenosis in the mid-segment. We continued with OCT and IVUS imaging to further evaluate the degree of restenosis and to further explore the results of these new scaffolds. What we discovered is that with conventional DES, there is some degree of neointimal hyperplasia, which is not so prominent with the bioadapter. This is obvious both with IVUS as well as with OCT. We can see that with OCT, the stent struts are well within the intima, while in the bioadapter, they're just under the endothelium. We also experimented with intracoronary nitroglycerin administration to see the results of the adaptation of the vessel to vasodilation at the segment within the bioadapter and within the segment of the conventional DES. And we saw that there was some some better response of the bioadapter to vasodilation compared to the conventional DES, but these results need to be further evaluated. Then we decided to measure the degree of in-stent restenosis at the site of the bioadapter, and we did the IVUS and co-registration, and at the site of the tightest lesion, there was a degree of 42.9 in-stent restenosis. And we further evaluated that functionally with IFR measurement, which was 0.92. So we decided to go with conservative management and not further proceed to any interventions and follow up the patient. We also established that there was no underexpansion of the stent, both with IVUS and with OCT. And we concluded that the choice of the stent was sufficient in order to avoid in-stent restenosis and late events, at least in the 1 year that we had the follow-up. So the bioadapter scaffold's design may permit better adaptation to native coronary physiology and might be a solution for diffuse disease, severe tortuosity, long lesions, and young patients. It's not very clear whether imaging can depict the differences in coronary physiology between bioadapters and conventional DES, although they are very useful. Imaging is very useful in the deployment and follow-up of the stent result, but their cost is slightly higher than the one of the conventional DES, so that prevents us from their extensive use and minimizes our experience with them so far. Thank you.
Thank you very much. Thanks to everybody. Just one question, if you have two questions. The thickness of the struts and the drug that you have, the bioadapter.
It's sirolimus and it's 71 micrometers.
71 microns, okay. From Dr. Patsourakos is the cath lab.
If we want to conclude this case, they say for this new scaffold that there is less late lumen loss. We saw it there. Truly, we had the opportunity to have in the same patient two different kinds of stents. In the one, we had a late lumen loss. In the second one, the new one, we didn't have. It's very interesting to see because if you see the picture angiographically, you could suppose that the vasomotion of the vessel was better after 1 year. I don't know if this could happen with the usual stents that we use. The other thing is that angiographically, someone could choose to open this restenosis. The IVUS told us that we had a restenosis of 42.9% maybe, isn't it so?
Yes, yes.
The IFR was 0.92. We do not know that if we had there a conventional stent and not the new one, maybe the IFR was not 0.92. This is a very good question. I don't know if there is an answer, but maybe you have some other.
I think,
no, I'm sorry, I was missing the first part of your presentation.
No, it's okay.
And I would like to have you back to the last angiographic images that you have shown.
Can I?
Is an AP cranial on the LAD, not the movie.
Yes.
AVI 5. Going back to the angio. Can you go back?
I can move it. I thought.
Go back.
Okay.
This
Yes.
one.
Yes, yes.
And I'm watching to the most tortuous segment.
Yes.
There was the lesion in the beginning. There was the lesion in the beginning. It was really
Okay.
tortuous and.
How do you judge this angiographically? Is what you are expected? It seems that the lumen is becoming where you have the flexing point a little bit smaller.
I think it's intramyocardial. It's almost a bridge over there. So the stent is a bit undersized, and I don't think it's stent stenosis. It's stent under expansion. So,
but if you are disconnecting the structure where you have a flexing point, do you think that is anyway is good or can make some?
Well, supposedly, in theory, this stent preserves the normal vasomotion. I'm not sure. We don't know.
I think there is, if you say it was already a tortuous vessel, I think I have no experience with this stent, but you think, in my view here, especially in the RAO, you can see that it follows the vasomotion of the vessel. There is some intimal hyperplasia, also imaging has showed us. But the patient is asymptomatic. I think you did a great job. Should we go for the presentation of the Dr. Karalis, and then we can discuss, please.